Code Status Discussions, a medical student primer. My name is Amolu Drunker, and along with Katie Dupre, we're going to talk to you about how you as a medical student can engage in code status discussions. Today, we're going to cover 5 topics of discussion. First, what is a code? 2, what are the typical outcomes of codes? 3, what is code status? And 4, what are the options for a patient's code status? Finally, 5, what are some tips and strategies for a code status discussion, particularly at the medical student level? Before we talk about code status, we should clarify what a code actually is. A code is the attempt to revive a patient who stops breathing and/or whose heart stops beating. In other words, a patient who experiences respiratory or cardiopulmonary arrest. You may be familiar with this more advanced medical terminology, but it's important to be able to relay these concepts in a language that patients can clearly understand. In a code, a medical team, that is, doctors, nurses, respiratory therapists, pharmacists, and you, the student, work together to restore a patient's heartbeat and breathing. This is accomplished with the following: chest compressions to maintain the heart's work of pumping blood to the body, electrical shocks and medications to help the heart reboot, in a sense, its normal rhythm and beat, manual ventilation, or breathing, to deliver oxygen to the lungs, and from there to the rest of the body. Again, while this might be elementary for you as a medical student, it's important to help patients who have not trained for or experienced the code understand what it actually involves. After all, you can't help someone decide whether or not they want something if they don't even know what it is. This takes time to explain, which is why doctors frequently either don't do it or do it incompletely. For example, you might hear a doctor ask a patient if they want everything done. If we don't unpack for patients what do everything really means, we can't be certain that they're acting in accordance with what they actually want. When talking to patients about their code status, it's also important to understand and communicate the outcomes that patients can expect from a code. In other words, do codes work? The short answer is, it depends. It depends on what the patient considers a successful outcome. It also depends on the patient's baseline health, that is, how healthy they are at the time of a cardiac arrest and what underlying medical problem or problems most directly cause their cardiac arrest. To frame your patient's expectations accurately, they should understand the rates of survival and the functional outcomes following a code. In patients who have a cardiopulmonary arrest during a hospitalization, the chance of surviving the attempt, meaning achieving a restoration of the patient's heartbeat, is about 40%. Of those patients, the rate of survival to discharge is about half, or 20%. And among those 20% of patients who leave the hospital, about 20 to 40% have a significant decline in their functional status. These numbers matter because when we ask patients what their chances of surviving a discharge are, their predictions in research studies are around 60%, or 3 times more than the actual amount. If we take the time to provide that reality check, it might change some patients' decisions about what they actually want us to do for them, or in any case, give them a practical context for making these big decisions. To help patients understand the risks, benefits, and potential outcomes of CPR, it's also helpful to take into consideration the medical characteristics that predict a better or worse outcome for each individual patient. Generally, patients who experience cardiac arrest as a result of isolated cardiac disease, like chest pain or angina, a heart attack, heart failure, or valvular disease, tend to have better outcomes. On the other hand, patients with advanced stage systemic diseases like cancer, cirrhosis, end-stage renal failure, or sepsis, as well as patients who are older or have dementia, tend to have lower rates of survival from cardiac arrest. Additionally, Even though it's less relevant to your code status discussion with a patient, you should know as a healthcare provider that patients who have shockable rhythms in cardiac arrest, like ventricular fibrillation or ventricular tachycardia, aka VFib or VTAC, do better than patients who experience pulseless electrical activity, PEA, or asystole. Now that we've reviewed the foundational medical information for a code status discussion, let's proceed to a discussion of what code status is. A patient's code status describes his or her preferences for what the medical team should do in the event that he or she stops breathing, or if his or her heart stops beating. There are several acceptable options for a patient's code status. A patient may choose to be full code. This means that in the event of a cardiopulmonary arrest, they approve of the medical team's use of whatever measures are required according to guidelines for cardiopulmonary resuscitation, CPR, or advanced cardiac life support, ACLS, to try and restore the patient's heartbeat and breathing. A patient can also choose to be DNR, which stands for Do Not Resuscitate. This means that if their heart stops beating, they do not want the team to do chest compressions, give electrical shocks, or administer medications to restore a pulse. However, it does leave open the option to place a breathing tube and use a ventilator to give breaths in the event that the patient stops breathing but maintains a pulse. Although our institution does not allow it, some facilities permit patients to be DNI, or do not intubate, which means that they are amenable to all aspects of resuscitation except for the use of a breathing tube or a ventilator. Finally, patients can choose to be DNR-DNI, which means they are neither comfortable with resuscitation nor with intubation and ventilation. It's important to check your state's and institution's policies before discussing code status with their patients, as these can sometimes vary from place to place. It's also necessary to confirm a patient's code status every time they come to the hospital, or if a major event occurs during their hospitalization, which might prompt a change in their goals of care. Finally, it's vital to communicate to patients that DNR, DNI, or DNR-DNI do not affect what care is provided to a patient outside of a respiratory or cardiac arrest event. Some patients or families will express concern that they might receive less aggressive care if they are not a full code, and this is not true. Now that we've set the context for a code status discussion, let's get into part 2. What are the tips and strategies that you, as a medical student, can use to bring all this information together into a code status discussion with your next patient? Now, we've mentioned these before, but because they're two big hurdles that patients and medical students sometimes encounter to having code status discussions, we want to say them again. First off, remember that you're not asking your patient if they want to die. You're asking this patient if they want to stay dead. Now, that's pretty tongue-in-cheek, but the point is that when you're discussing CPR and intubation with patients, it's important to emphasize that you're only talking about the specific circumstances in which their heart either stops beating or they're unable to breathe on their own. Also, remember that choosing do not resuscitate or do not intubate, or a combination of the two, does not mean do not do anything. Code status does not affect other portions of a patient's medical treatment or mean that the team will do nothing and let the patient die or suffer. As a medical student, you can and should discuss code status with each of your patients. Many medical students are nervous to ask about code status, feel that it is not appropriate for their level of training, or assume that the task is better fulfilled by another member of the clinical team. All of these are very much not the case. You have the knowledge and the time to discuss code status with every new admission, so why not use it? First off, why ask about code status? Asking about code status is an important part of your training. Just like any other skill, the best way to become comfortable with it is to practice it. And the more you practice, the better you'll be able to handle more challenging code status discussions. Think about it this way. Do you want your first time discussing code status to be when you're flying solo as a new resident? Next, when? Discussing code status and identifying a surrogate decision maker, should one become necessary, ought to be a standard part of every new history and physical you conduct. That includes patients who have a code status documented from a prior hospitalization, or patients who are transferred here from other hospitals. How? This can be a loaded question, and one we're going to continue to unpack in the next few minutes. For some patients, it's okay to have a very abbreviated discussion. For other patients, you may need to spend more time, especially if you suspect that DNR or DNR-DNI might be an appropriate choice for them. Also, remember that cardiopulmonary resuscitation is a medical treatment. Just like you would before a surgery, test, or invasive procedure, discuss its indications, benefits, and risks with the patient. And remember to tailor that discussion in the context of the patient's own goals and values. To break down the how in more concrete terms, these are 4 items that a code status discussion should cover. First, you want to prepare the patient. A good way to frame this is, even though we don't anticipate an emergency, we need to know what your preferences are if one happens. Next, describe what normally happens. It can be helpful to describe intubation and cardiopulmonary resuscitation separately so that patients understand what each one entails. Remember that resuscitation often requires invasive airway management, which you can explain to the patient, but also note that intubation can be a necessary situation outside of a cardiac arrest. Again, it is really, really important to use language that is appropriate to a patient's level of understanding and to ensure that patients have an appropriate sense of the risks, benefits, and typical outcomes of each of these actions. As we mentioned earlier, you want to take the time to understand the patient's perceptions, goals, and values. What are they thinking? What do they want for themselves, for their health, or their loved ones? What are the values that guide their decisions and their outlook? It can be challenging, but part of your role here is to help the patient match all of those questions to a code status that's consistent with what they want. Sometimes, the patient may ask you to make a recommendation. If this happens, and you feel that you're appropriately knowledgeable about the patient's condition, you should offer your input. That being said, remember that it's not about your opinion, but your impression of what the patient seems to want, based on what they have told you about themselves. You might consider putting this in language like, "From what you've told me, XYZ sounds really important to you. Based on that, it seems like ABC would best fit with that goal, because," and so on. A code status discussion can and should be part of your skill set as a medical student. Even then, it is okay to admit when you're in a situation that feels above your pay grade. While we want to prepare you to take on an expanded skill set, we don't want to pressure you to wade into uncomfortable territory. If you get into an area where you feel like a more experienced presence would help, you can pause the conversation. Tell the patient that you just want to introduce the topic for now for them to consider. Give them some time to think about it, and remind them that you will revisit the topic later. Also remind the patient that until they decide otherwise, the default full code status still applies. If you're discussing code status with a patient who you think might be near the end of life, you should invite your resident to either participate directly in the conversation or give you the go-ahead to engage the patient in what could be a highly consequential discussion. Finally, if the clinical team has decided not to offer resuscitation to a patient that it feels will strongly not benefit from it, that decision and the subsequent conversation should always involve an attending. To guide that code status discussion, here are a few quick do's and don'ts. Do be direct, comprehensive, and honest. Adjust the information and the discussion to a patient's knowledge level, and know what choices are available, particularly at your institution or in your area. Don't use shortcut language like do everything or heroic measures, as this may mean different things to different people. Also, don't lead the witness with lines like, "You don't want us to jump on Grandma's chest and break all her ribs, do you?" Okay, that one seems fairly excessive, but in general, leading the witness is something we sometimes have a tendency to do as clinicians, and we should remember that it's about what the patient wants and not about what we want. That can be a lot of information to retain. So if you forget, here's a mnemonic to help dial it down. First, contextualize. Why are we talking about this? What is a code? What happens in a code? Second, move to the prognosis. What are the options for a code status, and what are they likely to mean for a patient like you in your situation and with your medical conditions? Finally, offer reasoning and reassurance. Help the patient to make an informed choice. Reassure them that if they choose DNR or DNI, it will not affect any other part of their medical care. CPR. That can be a helpful mnemonic for you to remember in case you're revisiting this later for a code status discussion. As a result of viewing this presentation, you should now be able to 1. Explain what a code is, the steps and procedures it involves, and the benefits, risks, and typical outcomes of those interventions. 2. Describe the possible outcomes for code status and what each entails. 3. Help a patient select a code status which aligns with his or her goals and values. And 4. Identify circumstances when a more senior physician's input may be necessary. If you do not feel comfortable with any of these skills, we recommend going back and viewing the appropriate section of this presentation. Thank you for your time, and we hope you're prepared now to engage in code status discussions with your next patient.